And then, so this is a really good medium for headache specialists who have headaches or not, and headache sufferers, because, you know, you can, as you know, it's hard to go out there and advocate if you're having a migraine, and this is a wonderful alternative or additional method to do it. And I really enjoyed all the presentations, and it's really nice to take off your hat as a patient and a doctor and just mingle. And I really thank Miles for Migraine to allow us all to meet. So I just want to make sure everyone understands that it's not just migraine sufferers who feel lonely, it's migraine doctors too. And you might be surprised to hear that. Migraine doctors don't get all the respect and all the, you know, kudos that, say, a stroke doctor gets, an ICU doctor gets, an epilepsy doctor gets, a Parkinson's doctor gets, specialist, I mean, because, as you know, migraine is still considered a condition where just in your head. So it's nice to have a community that you belong to. Yes, we do belong to the headache doctors community, but that is small. And it's wonderful to be able to take, you know, to be included and to be feeling as if you're part of this group. And so I really want to thank Miles for Migraine. This is our third year we have been collaborating with them with our annual events. And it really has, I'm always very happy when we have these events and we get to meet a lot of people. So thank you for that. So my talk is Migraine Treatment Update, Current and Pipeline. These are my disclosures. I've previously spoken for or consulted with some companies. So there are 4 things I want to touch on today. The first is to recognize why migraine is so important in the global arena and also in the national arena. Secondly, we have to understand that migraine is a brain problem. And of course, we understand that at a, you know, gut level, but it is true scientifically. Learn about the current and future abortive treatment, and then preventative treatments. So Lancet Neurology is a very fine journal of neurology, and they published this study in 2017. And every 10 to 15 years, the World Health Organization will do a huge amount of data collection to look at what is happening with regards to all sorts of disorders, including neurological disorders. And they will come up with data as to how common is stroke in the world, and in the US, how common is Parkinson's. And this is a 25-year summary of neurological disorders from 1990 to 2015, and was presented in 2017. And if you look at this graph, the first thing that pops is the purple. The purple is stroke. And at the bottom, you will see the x-axis is 0 to 80, that is years. So people, imagine people there. So the majority of people who, and on the y-axis on the left-hand side is basically the disability. So this picture portrays that stroke obviously is the most common cause of disability as you get older, in your 50s, 60s, 70s, and so forth. And that's the dark purple. And then the lighter purple is as you get into your 50s to 80s, of course, one gets demented, and that's the commonest cause of disability as we get older. But then move your eyes to the blue and the orange and the red. That's where we live, our migraine people. The nice green is Parkinson's and epilepsy. But if you just look at a big picture here, the yellow, orange, and red indicates that throughout our life, from the age of 5 onwards all the way, and it peaks actually when we are at our best, in our 20s, in our 30s, in our 40s, and it goes on till the entire spectrum of your life. So basically, migraine affects every age. It, in fact, affects the peak of our life with regards to aging. And so it's the second most common neurological disorder to cause significant disability in the entire world, not just US. So imagine after stroke, this is the second one that creates all this disability. It's not Parkinson's, it's not epilepsy, it's not meningitis, it's not, Lou Gehrig's disease, it's migraine. So that's really important. This is a nice graph. You're all migraineurs, so this is not a surprise for you. There's a prodrome, meaning before you get this migraine, you have all these feelings and non-specific symptoms. And then after, some of us have auras, meaning you have the squiggly lines, you lose your vision, and so forth. And then you have, of course, the headache. And then there's a postdrome, which means basically after the migraine headache is gone, you still have all these variety of symptoms and you just don't feel yourself. So it's much longer than just the headache. And of course, it's preaching to the choir here. You guys know this. I love this description of headache, which was published by in the Headache Journal in 2018. And it was written by Dr. David Dodig from the Mayo Clinic. And it's an article describing the pathophysiology or the why migraine is a brain disorder. So it says migraine is not just a headache. It is an inherited neurological disorder characterized by an underlying state of increased responsiveness of cortical and subcortical networks that amplify the intensity of sensory stimuli. It is a syndrome, meaning it's a collection of symptoms, not just one symptom, characterized by disturbance of sensory function, affect, mood issues, cognition, meaning how you're thinking or not able to think, and autonomic function, meaning all the functions that you cannot control, like sweating and heart rate and feeling faint and so forth. So the reason I want to start here is you really want to understand what you can do or what are the treatments for migraine by understanding what is happening in your brain. Why is it happening? So migraine is a problem with neurons and blood vessels. So it's called neurovascular. And the main issue behind a migraine brain is that there is neuronal hyperexcitability, meaning it's the neuronal system is too excitable, especially in the occipital cortex, which is where your vision center is. So it makes the brain susceptible to migraine attacks like epilepsy. Of course, we know epilepsy, but we don't think of, when you're having an attack, you think clearly what the physical symptoms of epilepsy are. And we don't correlate it to a migraine headache because it's in your head. You don't see anything happening. So the best evidence we have for migraine being a brain problem is the aura, when some folks will see lights and flashing and so forth. So it is an electrical event in the brain. And this event has a name. It's called the cortical spreading depression. And interestingly, that event can be mapped out in every person, and it's the same rate for every person in the world, whether it's black or brown or white or short or tall. It happens at the rate of 2 to 6 millimeter per minute on the surface of the brain. So there's a change in chemical flow within the neurons, resulting in changes in electrical signaling, which leads to then changes in local blood flow. So let me see if this will work. This is supposed to be a video from YouTube, which shows how if you're experiencing an aura, which is little squiggly lines on your vision, this is what's happening inside your brain. This is mapping. As you can see, there is this electrical activity, the shining happening on the right side of the brain, while you're having some squiggly lights on the left side of your brain. So this has been captured. It's not voodoo. It's not something I made up. It's been captured now. Okay, how do I go to the next slide? Okay, so that was a very nice picture to show that when you're experiencing the aura or the warning, there's something actually happening in your brain. And if you do a special scan, we can actually capture it. And that's amazing to understand. For me, that's just always been mysterious and wonderful. So this is just a cartoon of the brain, and the top is the cortex and the middle part of the brain is the subcortical. And as you can see on the right side, it says plus K, meaning the potassium is leaking out, and it's trying to show you that's sort of the beginning of an aura, and then it spreads all over the brain. So I love to talk about this story. Dr. Weiler in 1995 had a patient who basically had breast cancer and was in a PET scanner getting a scan to look for metastases. And then that person had migraine. So while they were in the scanner, they began having a migraine. That time, triptans were available, specifically Imitrix, and they injected her with Imitrix, took her out of the scanner, injected her. The migraine went away right away because it was an injection, and then they continued to scan. Her headaches went away, but then when they were looking at this brain scan by chance, they discovered that there were these bright areas, the red dots, and that did not go away even after the headache went away. And that was the first inkling we had that there is actually a generator in your brain, which sort of can start your migraine. You didn't cause your migraine, it started spontaneously. And so there are many areas, and they're listed here. I wouldn't worry about the names of those areas, but the fact of the matter is deep inside your brain is this system which spontaneously starts triggering your migraine. And that's why some of you, when you come to clinic, you're like, no, nothing, my life is fine, there's no stress, nothing. Why did I get such a bad migraine which didn't go away? Now, if for the sake of argument, you said, well, how do we know it's a migraine? It could be a tension headache. So when you do a PET scan on a person who basically you rub chili peppers on their forehead or just smack them on their head a little bit, this is what will show up. The areas in orange are not the same areas as migraine. So basically, you can actually prove if somebody is having migraine versus tension or migraine versus sinus headache by putting them in a very, very expensive scan. Which of course we don't do, and our skill is in getting the history and pattern recognition and understanding what's happening to your body and diagnosing it. And it's actually foolproof. I mean, we make a diagnosis of migraine clinically. So I'm not saying that we need a PET scan to make a diagnosis of migraine, but if you really had to do that, you could. And so up to 3 days prior to migraine, you'll have a lot of these other symptoms: fatigue, mood changes, food cravings, yawning, muscle tenderness. And it points to the involvement, in addition to many other areas, to the hypothalamus, which is basically at the center for our clock, internal clock. It's a center for mood and for hormone changes. And that's why migraine is not just a headache. It has all these other additional things that are happening. And other areas of activation include the emotional system, the executive functioning, speech, and language. And this is a cartoon not to scare you, but just to put it all together. In the middle is the hypothalamus, and the signal flows from the hypothalamus. It goes down and then upwards, and upwards you see on the right-hand side a big red blood vessel which starts dilating, and then there's a spill of all these chemicals. One of them is called CGRP and the other one is called PACUP. There's only 2 mentioned, there's hundreds. And then you see this word called mast cell next to the 2 big red blood vessels. And mast cell, interestingly, is a key player in allergy. And a lot of us have this spectrum where is it my allergy? Is it migraine? And lo and behold, the mast cell guy is there, taking part in this whole battle that's going on in your head with the migraine onset. So there are all these players that are working hard to make that picture of migraine. And then again, this one is to just illustrate how many, this is not even a full picture. So in the middle, the idea is to show you how many chemicals are involved in migraine. It's not just one thing. And the reason I'm approaching it this way is because then there's not one thing that is going to cure your migraine or treat your migraine. It could be one for somebody and another for somebody else. So in the middle, you have the neuronal cell body, and there's inflammation there during a migraine. And on the left-hand side of my screen, there is the meninges, or the covering of the brain, and that's inflamed. So basically a meningitis picture of pain and neck pain and vision issues and photo and phonophobia comes up. You're suffering when you're having a migraine as much as a meningitis person is suffering. Why? Because your brain is inflamed like meningitis. It's just not from a bacteria. And on the left top where it says pungent odor, there are all these chemicals that are released when you are inflamed. For example, when your knee is inflamed from arthritis, these are the same chemicals that are floating in your brain when you're having a migraine. So it's all these chemicals that just converge when you're having a migraine. And on the right side, it shows how there is the brain, which is trying to send signals down to suppress the migraine. And then the signals are coming up from all these other areas to activate a migraine. So there is a literal war in your brain with all these elements trying to either create a migraine or suppress a migraine, and that's what happens. So moving on to acute abortive treatment, meaning what is the best treatment to stop an acute attack? Now, I know there are so many people who have this constant attack, like, constant. I always have a headache. It doesn't ever get better. But then you have these acute episodes where it's 10 over 10 or higher than your usual number. And the goal of acute treatment is to decrease your pain intensity by at least 50% within 2 hours of taking something. And that's what clinical studies use. And then the second goal is to stop the most bothersome symptoms. Now they have a word called MBS, and all clinical trials are using these standards instead of every clinical trial using some other new term. And so the idea is also to decrease not just by your pain, but what else is bothering you? Is it the nausea, the vomiting, light or noise sensitivity, whatever else it is? And so a busy graph, I try to see if I can make it really simple and funny, but this is, just boring science. So I just can't make it funny, I'm sorry. You'll have to bear with it if it's boring. But let's look at the left side. So the acute abortive examples, there are so many options, and you have to figure out what works for you. If acetaminophen works for you, or aspirin, or diclofenac, ibuprofen, naproxen, it's fine. Why? Because remember, there is inflammation in the brain going on with these chemicals that are suppressed by a simple non-steroidal. How about ergot alkaloids? So ergot were ancient. They were discovered by the Greek and Roman. The Greek Roman women would go to the fields, pick out a rye plant where this fungus was growing, and they would chew on the rye plant. And they discovered that when you chew on it, your pupils dilated and you look prettier, and then your migraines went away. And that's how they discovered ergot. However, it got a bad rap because if you chewed too much on it and you used your fingers to do it, your fingers would get dark and gangrenous and fall off because it was a very strong vasoconstrictor. Of course, these women didn't know that. And so it got a bad rap, but this group is wonderful. It vasoconstricts, meaning it causes the blood vessels to kind of go back to being a normal or maybe constricted level. And then triptans were discovered. They were the first sort of designer drugs that were discovered in the 1980s, which work on a certain receptor called the serotonin receptors. And there are 7 of those. And they all have different sort of profiles. So some of them work fast and work shorter. Some of them work slower, but work for many, many hours. And the reason why headache doctors succeed where maybe non-headache specialists just don't have the same success is because we sort of know each intricacy of each of these medications and try to match it to you and your migraine. And then there are combination pills, which some of us still take, acetaminophen, aspirin, caffeine, Fional, Fiorcet type things. And it has really fallen out of favor, this combination group. Why? Because acetaminophen or Tylenol kills you aspirin affects your kidney. And so if you're taking a combination pill, you are targeting your liver and your kidney and something else in your heart in the same pill, and causing, you know, long-term damage if you're taking a lot of it. And clearly these cause more medication overuse headache than others. And then there's this new class of medication called calcitonin gene peptide related peptide. Now the good or the bad news is that everything that was discovered for migraine was discovered by chance. And the reason this CGRP has a long and weird name is because it was discovered by chance. So when this calcitonin is a hormone, and the gene, they were mucking around, the physiologists, and were looking for this gene that releases calcitonin, and they found this other little molecule, which was by chance expressed. And when later they discovered that, wow, this is actually very powerful and important. And then we discovered so many, you know, the story of CGRP starts with being accidentally discovered while they were looking for another gene and another hormone. So that's why the very awkward name. And there are new acute abortive treatments. I mentioned a couple of them that have now been approved, FDA approved for acute treatment for migraine. So there are many options, and none of it, I mean, will it work for you? We don't know. You have to try something to know. There's no, you know, one size does not fit all. That's the problem. So the triptans work on this particular receptor called the 5-HT, which is a serotonin. And you've heard of serotonin as being the hormone that is involved in depression. So a lot of the hormones are affected in migraine are also famous or useful for other pathways, and those pathways cross. So that's why we have so many other disorders that coexist with migraine. And again, we're not saying depression causes migraine or migraine causes depression, but we know they coexist. And there's a lot of inflammation going on. In the middle here, you will see nociceptive and inflammatory neurotransmitter. I mean, our brain is on fire when we're having a migraine, and it's like meningitis. It's all inflamed. There's no infection there. That's the problem. Okay, so moving on to preventative treatment. Here is a list of medications discovered by chance. And just because some of these medications are ancient and doesn't mean they are less valid or less useful than some new fancy medication. The yellow is what has been FDA approved. And interestingly, there's not a whole lot FDA approved. So seizure medications, why do these work? It's not because you're having a seizure, and antidepressants don't work because you're depressed, or the antihypertensives don't work because I'm treating your blood pressure. They all work in a different way. They are stopping your brain from leaking the chemicals, and then the chemicals causing electrical activity, and the electrical activity causing blood pressure, blood vessel changes. So this cascade, they're doing other things. So valproic acid, topiramate are FDA approved. There are others that we use. You could use basically any antiepileptic or most of them. The antidepressants, the class that is more powerful and has more data is the TCAs, which is the tricyclics, the older ancient one, which nobody uses for depression anymore, but neurologists use for headache at much lower doses. And the SSRIs that are very famous, you know, the Prozacs and all those, they're not as powerful for headache management as things like the combination ones, the serotonin and norepinephrine combination blockers. And I mentioned venlafaxine and Wellbutrin there, but note that none of those are FDA approved. So we are using a lot of medications off label, and that also creates problems because insurance may deny you something. And the reason a lot of these are not FDA approved because these are a lot old medications. Nobody wants to spend NIH dollars on research on migraine, and which we're fighting, of course, now, but you know, that's the main reason. Antihypertensives are pretty good for blood pressure and, of course, for migraine. Beta blockers are FDA approved. So propranolol, timolol, and so forth. And then on the right, there are all these newer medications that are FDA approved. Of course, you know, botulinum toxin is FDA approved for migraine. By chance, women were getting cosmetic Botox, and then suddenly their headaches got better, and insurance fought it for years. They thought women just wanted Botox. So they were, you know, it's the funniest thing. For years, even after the FDA approved Botox, insurance companies would deny it. They'll be like, they just want Botox for cosmetics. And then remember we talked about the CGRP. So this molecule, which has just been discovered by chance, now it's a favorite target. And we have all these different medications that are injectables that are FDA approved. And I have a list in the next slide. Now, there are a lot of nutrients at certain doses, and I put them in yellow. They're not FDA approved, but they have good data. Biofeedback is actually FDA approved as a listed. And on the right, the list is short, but as you know, you had some excellent talks about what alternative medicine or complementary medicine or other treatments can help migraine equally as pills. And going back to the left, there is coenzyme Q10, which has a small set of data. There are two herbs, butterbur and feverfew. Over the years, they have collected some small studies on efficacy. Again, melatonin has a little bit of efficacy, and there's a question about turmeric. I've heard a lot more about turmeric recently than in the last few years. None of this is FDA approved. I want to go back to the CGRP because that's kind of the craze of the day or the year. And this molecule, which was discovered by chance, is present everywhere in your body. And it is released when you have arthritis pain, it's there in your joints. When you have a heart problem, it's there in your heart, in your kidney. So it's everywhere. And when you're having a migraine, it's triggering it by increasing the level in your brain. And scientists have looked at levels of CGRP on the left, which is normal. And then if you have high CGRP levels, for example, if you inject someone IV with CGRP who has the gene for migraine, they will start getting all the stuff that is usual with migraine. They'll have pain and light and smell and sound and sensitivity and so forth. So it is proven that high CGRP in your brain, especially if you're a migrainer, will cause all those symptoms of migraine. So the timeline for migraine bonanza, I call it, is very exciting since 2018. Before that, Botox was the one that was FDA approved for chronic migraine, and we kind of hit sort of first CGRP receptor antagonist or monoclonal antibody, which is subcutaneous monthly injectable, was released, was erenumab. And then in April, then in June, they released galcanezumab. Then in September, fremanezumab. And they're all similar. They're all monthly injectable. Some of them are a little bit different. For example, the Frema is monthly or quarterly, but they're all indicated for migraine. And the good news is it's indicated for episodic or chronic migraine. So if you have 4 headache days a month or more, or any number, you can still be eligible. So that's the good news. Galcanezumab also is approved for cluster, and I know many patients personally who have cluster and migraine. It's highly underdiagnosed. So that's an advantage there. And then moving on to 2019 October, this slightly different class called lasmiditan was released. That was for acute treatment. And then in 2019 December, another acute treatment option, ubrogepant, which is a CGRP receptor molecule, was released or approved by FDA rather. I'm not sure how I'm doing for time. Eftinezumab is an intravenous CGRP receptor antagonist, which was released in February, and it's quarterly. And then in February, again, this small molecule called rimegepant, which is again the CGRP mode of action was released for acute migraine. So the interesting thing with this class is that it will help both your acute attacks and your preventative. And we are getting newer treatments for acute versus for chronic. And that's the first time in history that we have a molecule that pharmaceuticals and research is showing you can target it for acute and for chronic treatment. And this is just a list to show you that there were some great studies done. On the left is the name of the drug. On the middle, the dosing is all this basically the same except the fourth one, which is intravenous. They're generally monthly, and there are a bunch of trials. I mean, when you have an FDA approved medication, it has done at least 2,000 or 3,000 patients trial. So there are all these studies listed in the middle. And the good news with this group, I'm amazed and just, I think it's a miracle to be honest, is which drug do you not see any side effect listed under FDA? And all these newer ones, basically the only side effect listed is injection site reaction under FDA labeling. So erenumab, which is Aimovig, has a constipation labeling, but otherwise they all are, pretty harmless, which is wonderful. And just to tell you, even though I use the word miracle, I want to keep it very rational and logical. And that is here, if you are taking anyone, this is just an example. I don't have time to show you each drug, but the example is if you are using galcanezumab, just example, you are in the red group, that is you're taking the medicine, you will have 4 less headache days in the month compared to what you were having. So suppose you're having 10 headache days, you're gonna have 10 minus 4, so 6. And so that is true for all the 3, more or less. It's 4.5, 4.4. So it's not as if all your migraines are gonna go away. However, there was a small group of patients in some of these trials which showed a better response. And then I'm going to move on to this picture, which is quite famous. It's come from the Botox Allergan people. Botox is FDA approved for migraine. And this is the set protocol to inject Botox. So there are all these areas. Botox is FDA approved for chronic migraine. And the definition of chronic migraine to get approval for Botox per FDA is 15 headache days per month that each day lasts more than 4 hours. And the interesting thing about the 15 days is not all days have to be severe migraine days where you're puking and have severe headaches. It could be 8 of those days are valid migraine days, and the others could be just headache days. And that's really important when your doctor is trying to get you approval for all these different medications. We really have to understand what the FDA has looked at and how this labeling has come about to be able to advocate for our patients.
Dr. Sahai, I don't want to interrupt you, but we're about 15 minutes over time, and I just want to make sure we have a couple of questions coming through, and I know you still have some valuable information. Do you have some insight into what you see on the horizons in terms of innovation and hopefulness in terms of new
Why don't I,
treatments?
yeah, so, there are a lot of devices, and the migraine treatment is such a big field that 30 minutes is just not enough. But why don't I just wrap it up quickly, and then we will have time for questions. I do want to show you a few slides on the devices because the device market is just flooded right now. And so I think that's really important. I will tell you that our approach at USC, and we've published this, is a multidisciplinary approach which involves neurology, occupational therapy, physical therapy, and pain psychology. And pardon me if I'm gonna skip some of these slides because of time. What we have shown that your health-related quality of life improves if you add occupational therapy to your usual treatment. So that's what this slide shows. And going on to other treatment options, I'm sure a lot of you have experienced peripheral nerve blocks, which are quite safe, low risk, high yield, Novocaine, and we use various peripheral nerves and the injection can last 4 to 6 weeks. And here is a picture of the various nerves that we can approach. Now, moving on, there's this new device called Nerivio, and basically it's a battery-powered little electrical current that you receive on your arm, and you control that with your smartphone. There is the transcranial magnetic stimulation, which is an external device which you zap on the back of your head when you're having an attack. There is this Cephalid device, which there was Cephalid 1, which is the top, and then the Cephalid 2, which is a modified version, and you could use the Cephalid device either for acute attack or to prevent an attack. Then there is this other device called Gamma Core, which stimulates your vagus nerve and can stop your migraines, and it's FDA approved device for that. And then there's other more serious things like implantable stimulators. We do blocks at our location with just a simple syringe and not injecting, but inserting a small syringe and putting some lidocaine into the back of your nose called sphenopalatine ganglion block. More serious procedures done by pain management called radiofrequency ablation. Then there is decompression surgery, which is of course a big surgery. And then there's a bunch of infusions or injections for migraine for which you have to come to your headache specialist office, and there's a whole list there. So I'm gonna summarize. Before I end the summary, I wanna tell you that the device market is very busy, but just remember that devices just need maybe 100 or 200 patients. And then they will, if they're positive, the FDA gives them approval, which to me is a little bit ridiculous. Whereas for meds, you have to do 6,000 or 2,000 or 3,000 patients trial. So I think the problem with the devices is that they have been tested with very few patients. And doesn't mean that it won't work. It just means that as a physician, I feel that I need more data to recommend them to my patients, so that, and especially some of these are expensive, the insurance won't pay for you to buy them, and would I want to have you spend your money on that? In summary, each migraine is as different as each individual. There is no one size fits all for migraine treatment. Often a combination of options work for each. Find your migraine village and don't give up. And I will stop sharing now.
We could have you on all day. That was so informative, knowledgeable, resourceful. We have unlimited amount of questions coming through for you. I think if anything to take away from your talk is that it's a very complicated neurological disease. And it's also how important it is to have a team or a specialist that has a team behind them, such as you do in your organization, to find a treatment that works, because it's just very complicated. And as you say, there's not a one size fits all. I want to thank you. You were extremely knowledgeable. I wish, as I say, we could keep you here forever. But I guess it's interesting, your comment on devices. Do you have one question that just came in? Do you have any devices that you feel have enough evidence to proceed with? I thought that was a powerful statement that you made about devices that's required very little testing.
So I looked at it last night when I was, the one thing we want to be is we want to be objective for our patients. Mm-hmm. And for, most devices, the Cephalid, initially when it was approved, were like 50 patients each group. And now what I see is basically it's 200 for everything. I looked at Gamma Core, I looked at Nerivio. Everything has basically about 200 patients listed, which isn't bad, but I mean, how many migraineurs do we have in America? 38 million. Mm-hmm. We tested 200 patients. So the good news is, ladies, if you have a spoon and you want to bang your spoon and your migraine goes away, just get it tested in 200 people. You might actually get rich. No, I'm being facetious here, but the point I'm making is
Understand.
I am not going to recommend, so the point is, I am very careful about
Mhm.
what you spend and in what. How will I tell you buy the near review when I know you're going to maybe spend $200 or versus Gamma Core? I mean, if the insurance covers it, I'll write for it, anything. It doesn't
Mhm.
matter. You have to try each one of them. I don't
Mhm.
know what will work for you, to be honest. Nobody knows based on the 200 patients. And here's the other fact. Every study has about 40% response rate, whether it's pills, whether it's prescription medicine, whether it's devices. Don't be fooled. Whether it's injection, whether it's Vyepti, nothing is 100%. So if you flip a coin, your chances of having success with anything you ask me is 50-50 or 40-60. So the good news I see is I am happy to go through the list of everything that is on there and go through each one with you and fight on it with your insurance, and something will work. The chances are 40-60.
Mhm. Interesting perspective. I have to go back to an early question that came in because it comes in a number of times, and I don't think we've ever asked it. So it says, could you discuss some possible preventative and abortive treatments for women with chronic migraine that want to get pregnant?
That is a whole 30-minute talk.
Okay, so maybe we need to pursue that. Okay.
Yeah, we should. I'm happy to talk about it, but
Okay.
I don't want to shortchange you
Yes.
ladies. And if
It's
there's
a
a man, hello man. I don't want to shortchange you. This is not
okay.
an, it's easy and it's difficult, okay? I mean, I can just throw out a couple of things, but I think it would do you a disservice.
Okay, I think that's a valid, we've received it before, so maybe we should pursue that as a concentrated presentation with you that would just address people that are interested in that time period. Here's a good one that came in that said, a trigger for me is often the period of time after high levels of stress. Can you
Absolutely.
explain what's going on a chemical molecular level in the brain in that situation?
Have you heard of letdown migraines? If you haven't, you just heard it. It's it's well known for centuries. Any change, the migraine brain, and whoever knows me I'm quite repetitive. The migraine brain is like a second grader brain. It likes consistency. It likes that, meaning if the stress level, too much sleep is bad for you, too little sleep is bad for you, too much happy causes a migraine, too sad causes a migraine, too much exercise causes a migraine, too little. Why? Because the migraine brain is special. It likes the consistency. It likes the mindfulness. It likes the steady state. It does not like a sudden surprise. Why? Because your sensory system is so high wired. So you have a little sun, you go out in the sun, and if you're not migraine, you'll be fine. If you're in the sun, the migraine brain is like, oh my God, trauma, protect this person. Your migraine brain loves you too much. It's always trying to protect you from what is perceived by it as danger and trauma, which it really isn't. So your sensory system is so super sensitive that if you go out in the sun or you smell some perfume or you are let down your guard, it triggers a migraine. Does that answer your question, Kayla?
I totally understand that analogy. I think that's a very powerful analogy for people to take away from that does help explain what's going on with their migraine brain. So I appreciate that. One question came in about, is aura related or similar to what happens with a stroke?
No. So this is, again, a topic that I would suggest you bring in and give us like 20 minutes for that, because it's a very complex topic. I will just tell you that, the American College of OBGYN has basically listed as if you're having aura and you're young, they won't give you the hormone replacement, which to me is problematic. There has been a lot of literature about aura causing, or people with aura having strokes, and people get overtreated, mislabeled people, and it's a very problematic topic. So the reason it's not a stroke is because when you're having a stroke, one blood vessel is constricted, the blood supply to that area stops, and then you have a stroke. In aura, there's all this electrical activity going on in your brain, but it crosses blood barriers. So it's happening in random areas. So it's not following a vascular pattern. So when you're having an aura, not only your 5 freeways affected, is the 101, there's a little, it's like mishmash. So it's not a vascular problem. And does it make sense?
I understand.
Explanation. Your questions are wonderful, and they really deserve a lot of discussion.
I agree. And you are extremely knowledgeable and passionate and clear on helping us understand what's going on with this neurological disease. And I thank you for that. And with that, as I say, I feel like we could keep you on all day. And amazingly enough, the majority of our participants are so interested, they do want to stay on, but I have to be mindful that we probably have to conclude our programming for the day. It's hard to do that when you have someone so engaging as this lineup that we've had today, because you just want to share as much information and resources as possible. But I do want to thank you, Dr. Sahai. You've been extremely, extremely well received and really great. I'm sure a lot of people are thinking, I wish I had her on my side and I could go see her because you have a lot of great knowledge behind you. So I will say that we must conclude our programming for the day. And I do want to remind each of you, we thank you for being with us. We will send a brief survey. We'd love to hear your thoughts so that we can make changes. I already have a couple ideas for some subsequent topics. So hopefully we'll see Dr. Sahai again, because she has a lot more to say on many other topics. So we want to thank our sponsors and thank you. Please take a look at our website for upcoming events and our mindfulness program, because I think some of you may find some value in additional series that we have to offer you. Thank you.
Thank you, Helen, for organizing it and doing it so smoothly. You're wonderful.
Oh, you're great.
Bye, everyone.